Good morning. I am Dr. Bensi. Today we are discussing about echo assessment of aortic regurgitation. We are discussing it like introduction, etiology and mechanism of aortic regurgitation, assessment of AR severity, role of TE management. These are the notes which help me in my DNB final exam. Aortic regurgitation is defined as the diastolic incompetence of aortic valve with the subsequent regurgitation of the blood back from aorta into the left ventricle. It frequently develops in patients with bicuspid aortic valves, degenerative process related to aging or diseases of the aortic root and ascending aorta. In India, rheumatic and bicuspid aortic valve, the most common cause for aortic regurgitation. It's more common in males. Prevalence increases with age, mostly seen in 4 to 6 decade. Physiologic or mild degrees of tricuspid and pulmonary regurgitation are commonly noted in normal individuals. AR is not. Normal subjects younger than 40 years of age, significant aortic regurgitation is rare, occurring in less than 1%. Echo plays an important role in the overall assessment of AR and in the timing of surgical intervention. This is the anatomy of aortic valve and aortic root. Look down. This is the blue one, okay, is the sinotubular junction, and this is a crown-like ring, and this red ring is the anatomic ventriculoarterial junction, and this green one is the virtual ring formed by the joining the basal attachments of the aortic valvular leaflets. Understood? Then look down. This is the anatomical cut down, and the blue line is the sinotubular junction, and this red dotted line is the crown-like ring, and this yellow line is the anatomic ventriculo-aortic junction, and this blue arrow shows the aortomitral curtain, and this one is the virtual ring formed by the joining basal attachments of aortic valvular leaflets. This is the membranous septum this arrow shows. Then look on this. This is the aortic annulus is the green, and this part contribute, the lower part contribute the aortic root, and the upper part is the ascending aorta. The purple ring shows the sinotubular junction, and this prominent sac-like structure is the sinuses, and this is the aortic annulus. Okay. Then in the echo, it's look down in this picture. This lateralmost picture. This is the left atrium, and this is the LVOT, and I will show. This is the LVOT, and this is the aortic valve. This is the aortic valve, and this is the sinus of Valsalva, and this is the sinus, and this is the sinotubular junction, and this is the ascending aorta. Okay. Then in echo, okay, this is the parasternal long axis view, and we can get the aortic diameters like this. Okay, the red line is the aortic valve, and second one is the sinuses, and third one is the sinotubular junction, and fourth one is the ascending aorta. Okay, and it's labeled in this picture. Second one, this is the LV, this is the LVOT, this is the annulus, and the yellow one is the sinus of Valsalva. This is the sinotubular junction, and this is the ascending aorta. Okay, then we coming to the etiology of aortic regurgitation. Congenital or leaflet abnormalities. These are the bicuspid, unicuspid or quadricuspid aortic valve. Then next one is the ventricular septal defect. Acute leaflet abnormalities: senile calcification, infective endocarditis, rheumatic disease, radiation-induced valvulopathy, toxin-induced valvulopathy, anoretic drugs, 5-hydroxytryptamine, carcinoma. Okay, then the congenital or genetic aortic root abnormalities are aneloaortic ectasia, connective tissue disease like Louis Dietz, Ehlers-Danlos, Marfan syndrome, osteogenesis imperfecta. Acute aortic root abnormalities: idiopathic aortic root dilatation, systemic hypertension, autoimmune disease, SLE, ankylosing spondylitis, Ritter syndrome, aortitis syphilitic, Takay's arteritis, aortic dissection, trauma. Then functional classification of aortic regurgitation is Carpenter's classification. In mitral also Carpenter's. AR type 1 is normal cusp motion with aortic dilatation or cusp perforation. This is type 1 is whole normal cusp motion. There is cusp motion is normal, but there is aortic dilatation or either cusp perforation which results in AR. Type 2 there is cusp prolapse. Type 3 there is restriction of the motion of the cusp. Okay, type 1 normal cusp with either aortic dilatation or cusp perforation. Type 2 is there is cusp prolapse, and type 3 is cusp restriction. 2D echo assessment, cusp pathology. Look on the cusp, aortic cusp, redundancy, restriction, cusp height to indicate likely adequacy of coaptation, mobility, pliability, thickness, integrity. Commissure variation, fusion, splaying, attachment site and alignment. Root morphology, septal hypertrophy, annular size, sinuses and sinotubular junction dimension, ascending aorta dimension. This is the aortic short axis, and it shows there is it shows there is restriction of the cusp. Okay, look at this. There is aortic regurgitation because of the bicuspid aortic valve. Okay, then this is the normal tricuspid aortic valve. Look at this, the left right hand side. This is the tricuspid aortic valve. The RC is arising from the right side, and left main is arising. There is left cusp, and this is a non-coronary cusp. Okay, in bicuspid aortic valve type 0, there is no cusp. Only there is like this. Only opening is like this. Okay, then type 1 is there is a raphe between the right and left, but only only two cusp. Okay, between the RC and left main. Okay, in type 2 is the cusp is between the right and left. There is no cusp in the non-coronary. It is a raphe is there. Okay, there is horizontal, vertical, left and right. Okay, these are Sievert's classification. Look down this. This is a normal tricuspid. This is the horizontal opening. This is the vertical opening. Okay, this is the left and right and non-coronary cusp is only there. This is the left and non-coronary cusp, and two raphe. Two raphe results in unicuspid aortic valve. Okay, this is the Sievert's classification. Next one is 2D echo. The presence of a flail valve is specific for severe aortic regurgitation. Reverse doming of the anterior mitral leaflet. Okay, measurement of the aortic diameters we already discussed. Valve annulus, aortic sinuses, then sinotubular junction, proximal ascending aorta. Example of this is an example of the AR jet impinging on the anterior mitral leaflet with a reverse doming of the anterior mitral leaflet, which indicates which impinging on the anterior mitral leaflet, which results in the reverse doming of the anterior mitral leaflet, indicates severe AR. These are the normal aortic dimension. Sinus of Alzheimer male, that is 13.8 to 21.8, and in female 13.1 to 20.7. Sinotubular junction 11.4 to 18.6, and in female 11 to 17.8. These are while we doing echo for the pre-TAVI investigations. Okay, proximal aorta 11.5 to 19.9, 11.4 to 19.8. Normal indexed aortic dimensions. Okay, this is from 2020 British Society of Echocardiography. Then we come to the chronic versus acute AR. Etiology: in chronic there is bicuspid valve hypertension, First one is bicuspid valve, second is hypertension, acute endocarditis, aortic dissection. LV size is dilated in chronic and normal in acute. LV-EDP is normal in chronic because it's compensating. In acute, it's elevated. Pulse pressure is wide in chronic AR and narrow in acute. Continuous wave Doppler slope flat and steep in acute AR. Okay. Then coming to the response of LV to acute aortic regurgitation. Most common cause are infective endocarditis and stand for type A aortic dissection. In acute aortic regurgitation, there is sudden increase in the LV end-diastolic volume or pressure, which results in increased left atrial pressure and pulmonary edema because it is connected to the LA, which the regurgitation is going to the LV, then it's going to the LA, which results in pulmonary edema. So, which results in the afterload increases, and which also results in decrease in the stroke volume and tachycardia. The LV-EDP approaches aortic diastolic pressures and coronary perfusion pressures. Okay, when the LV-EDP approaches the aortic diastolic pressures and the coronary perfusion pressures, the coronary perfusion will decrease. Okay, so because the coronary perfusion is depend upon the difference between this aortic diastolic pressure and the LV-EDP, which results in the myocardial ischemia, okay, which results in chest pain and decrease in the blood flow to the myocardium. Response of the LV to the chronic AR. In chronic AR, LV adapts to accommodate the increased LV and diastolic volume. Chamber compliance increases and eccentric and concentric hypertrophy occur so that filling pressure remains normal or near normal. Chamber dilatation allows for preserved stroke volume even though afterload is also increased. Over time, often years, LV systolic function worsens and patients may begin to experience heart failure symptoms such as dyspnea and lower extremity edema. Indication for echo in AR. To confirm the presence and severity of the AR, acute or chronic, to diagnose and assess the etiology of AR, to assess the aortic root dimensions and AR severity in patients with aortic root dilatation, to assess the LV dimension and systolic function in chronic AR upon initial diagnosis. This is the ACC/AHA 2014 guidelines for the management of patients with valvular guidelines. Indications of AR continued to reassess LV dimensions and systolic function periodically in asymptomatic patients with chronic severe AR, to reevaluate mild, moderate or severe AR in patients with new or changing symptoms. Then assessing the severity. First, while you are doing echo, you have to look on the color Doppler. Qualitative method. First is jet width per LVOT width, jet area by LVOT area. Then semi-quantitative parameters are vena contracta. Quantitative method is PISA method, volumetric method. First, Doppler method. Diastolic flow reversal in descending aorta, mitral Doppler pattern, continuous wave Doppler of the regurgitant jet. One is qualitative method, jet width by LVOT width, and second is jet area by LVOT area. Okay, we have already discussed. I will explain this. Method of choice to diagnose AR is color Doppler. AR of any magnitude indicates pathology. Three components of regurgitation. There is a proximal acceleration. Then look on this, the proximal part of the AR, and then there is vena contracta, the narrowest part, the two green arrows, and the expanding jet of the AR in LVOT. Look on this picture. I will show. This is the proximal acceleration. Then this is the this arrow is the vena contracta. This is the expanding jet of the AR in LVOT. Then central jets are suggestive of rheumatic disease. Eccentric jets are often associated with aortic valve prolapse or perforation. The maximum color jet diameter width is measured in diastole immediately below the aortic valve at the junction of the LVOT and aortic annulus in the parasternal long axis view. Jet width is proportional to the size of the aortic valve defect. The jet width is proportional to the size of the aortic valve defect. Okay. Then jet width by LVOT, how to measure? To assess the severity of the regurgitation semi-quantitatively. Planck's view is the best view, just apical to the aortic valve. Okay. Zoom the zoomed view, measure in LVOT with the 1 centimeter of the vena conductor. This is the green arrow is the vena conductor. Vena conductor, just look, this is the vena conductor, just proximal between the LVOT and the valve annulus. Okay. Then In the plaques view, zoomed view, just apical to the aortic valve. In the zoomed view, measure the LVT with 1 centimeter of the vena contracta. Then the mild is less than 25%, moderate is 25 to 64%, severe is greater than 65%. First, measure the jet width. Okay, jet width and then the LVOT. Okay, LVOT measurement. Okay, then divide. Okay, this mild is less than 25%, moderate is 25 to 64, severe is greater than 65%. Look, this is the jet width by LVOT width. Okay, first one is the LVOT. Okay, the LVOT is measuring. Then next one is the jet width. Okay, is about 75%. We can see, I will show you, this is the LVOT measurement and this is the jet width. It's almost 75%. Okay, then next one is jet area by LVOT area. The jet area by LVOT area is measured in short axis view in the zoom view. Okay, I will say which estimate the regurgitation orifice area. Okay, look, this is the short axis view and this is the this is the regurgitation area. Without regurgitation, measure the LVOT area, and then this in the zoomed view measure the jet area. Okay, jet area by LVOT area. Mild is less than 5%, moderate is 5 to 59%, severe is greater than 60%. This jet area by LVOT area is not valid in eccentric jets, okay, which is directed towards the septum or anterior mitral valve or in multiple jets. This is the you can see here, this is the LVOT area and this is the jet area, so which is actually more than 60%, which indicates the severe aortic regurgitation. Okay, this one, look, this is the here, this is the LVOT area and this is the jet area, which is 11%, which is suggestive of moderate aortic regurgitation. Okay, then advantages and pitfalls, which is the simple sensitive screen for aortic regurgitation and which is rapid qualitative assessment. Everyone can do in the echo lab. Pitfalls: underestimates in eccentric jets, overestimate in central jet, as air jet may expand unpredictably below the orifice. Is affected by the size of the LVOT. Absolute value of jet width to LVOT depends on the body surface area for the same severity of AR. Assessing the severity, we have discussed two methods, which is qualitative method, next is quantitative method, PISA method, and there is volumetric method. Okay, then semi quantitative parameters is vena contracta. Next is vena contracta, the best visualized and measured in a zoomed plaques view. Apical long axis view can be used. Okay, it is a narrowest area of the jet. It is smaller than the jet width in the LVOT. Careful probe angulation to optimize image. Nyquist limit to perfectly identify the neck, narrowest portion of the jet. Narrowest Doppler sector, magnify image, zoom, average over 2 to 3 bits in two orthogonal planes. Measure the smallest width immediately distal to the direction of the jet. Okay. Sensitivity 81%, specificity is 94%. Mild is less than 0.3 cm, moderate is 0.3 to 0.6 and severe is greater than 0.6 cm. Okay, look, this is the LVOT. Okay, this is the aortic valve and this is the LVOT. Okay, and the aortic regurgitation is going through here, and this one is the narrowest, this two is the narrowest portion. Okay, now this two white, this is the narrowest portion. Okay, in the zoom view, you can do the zoom view and look in the narrowest portion. This is one, and this one is the first one is mild and second one is severe aortic regurgitation. Okay. Advantages: surrogate for regurgitating orifice size, useful in eccentric jets, independent of flow rate and driving pressure, less dependent on technical factors, good at identifying mild or severe AR. Pitfalls: problematic in the presence of multiple jets, convergence zone needs to be visualized. Direction of the jet in relation to the insolation beam will influence the appearance of the jet. Okay, then coming to the quantitative method, PISA method. Okay, PISA method, that is flow convergence PISA method, based on the hydrodynamic principle that the flow profile of the blood approaching a circular orifice forms concentric hemispheric shells of increasing velocity and decreasing surface area. Goal of the PISA method to calculate the effective regurgitant orifice area. Okay, then flow convergence used qualitatively and quantitatively for evaluation of the AR severity. Zooming on the LVT in either the plaques or apical long axis views with a baseline shift of the Nyquist limit to measure the flow convergence radius. Measure of the AR peak velocity and the velocity integral by continuous wave Doppler allows calculation of the ROA and the regurgitant volume. Severe AR, effective regurgitant orifice area greater than 0.3 cm square and regurgitant volume greater than 60 ml. Okay. PISA quantitation of AR is used less often than in MR, as the flow convergence is in the far field and may be shadowed by aortic valve thickening and calcifications. Imaging from the right parasternal window may be helpful. Okay. Pitfall: multiple jets, constrained jet, aortic wall, non-hemispheric shape. PISA flow is equal to AR flow. 2 pi r square into PISA velocity is equal to effective regurgitant orifice area into AR velocity. 2 pi r square into alias velocity equal to ROA into AR velocity. Effective regurgitant orifice area is equal to 2 pi r square into alias velocity by AR velocity. Regurgitant volume is equal to ROA into velocity time integral of the AR jet. Okay. Look here, this is the by measuring the PISA. Okay, this is the radius formed, and by from the continuous wave velocity of the aortic valve we can measure the velocity time integral, and the ERO is measured from the PISA method in the aortic long axis. Effective regurgitant orifice area is equal to EROA is equal to 2 pi r square. R is measured from the from the radius is measured from the apical long axis, by AR velocity is measured from the continuous wave Doppler. Okay, so we get it as 1.5 centimeter square. Regurgitant volume is equal to EROA into VT of the AR. Okay, VT we get from the continuous wave Doppler of the air jet. Okay, so regurgitant volume is equal to 1.5 from the first one, 1.5 into VT of the air from the continuous wave is equal to 70.5. Okay, so regurgitant volume 70.5 is severe, that is in severe regurgitant volume is more than 60, moderate it's 30 to 59, mild is less than 30. Regurgitant fraction is less than 30 in mild, and moderate 30 to 49. Severe is greater than or equal to 50. EROA is less than 0.1, moderate 0.1 to 0.29, severe greater than 0.3. Pitfalls of the PISA method is feasibility is limited by aortic valve calcification, not valid for multiple jets, less accurate in eccentric jets, small errors in radius measurement can lead to substantial errors in ERA due to the squaring of error. Volumetric methods, quantitative, valid with multiple jets and eccentric jets. ERO is equal to regurgitant volume by VT of the regurgitant jet. Regurgitant volume is equal to stroke volume in the LVOT minus stroke volume in the mitral valve. Stroke volume is equal to cross-sectional area into VT. Regurgitant fraction is equal to regurgitant volume by stroke volume of the regurgitant one. Elevated diameter in systole and pulse wave Doppler from the apical view. Mitral annulus measured at mid-diastole. Pulse wave Doppler at the annulus level in diastole. Here we are measuring the LVOT VT in the pulse wave Doppler. Okay, then here we are measuring the mitral valve in flow Doppler. Okay. So regurgitant volume is equal to stroke volume LVOT minus stroke volume mitral valve, which is calculated as cross sectional area into LVOT VT minus cross sectional area into mitral valve VT. Okay, so 0.785 into 3.2 into 3.2 into 14.8 equal to 201 ml minus mitral valve. Okay, so regurgitant fraction is equal to regurgitant volume by stroke volume of the regurgitant valve. Pitfalls: difficulties measuring mitral annulus diameter with annular calcification, not valid for combined MR and AR. Assessing the severity by Doppler method: diastolic flow reversal in descending aorta, mitral Doppler pattern, continuous wave Doppler of the regurgitation jet. Then pulse wave Doppler, flow reversal in proximal descending aorta. Align is insonation beam with the flow in the proximal descending or abdominal aorta. Simple supportive sign of the severe AR. More specific sign if seen in abdominal aorta. The end diastolic velocity greater than 20 cm. This is the end diastolic velocity, which is the in the suprasternal view. Look, here is the suprasternal view, and this is the normally blood is going like this, and the flow is like this. Red beam is shown, that is it is the flow reversal. This is the flow reversal. Okay, and when we put the pulse wave Doppler across it, we can see this is the end diastolic velocity. This end diastolic velocity is more than 20 cm per second, is suggestive of severe AR. Okay, look, this is the and look, this is the pulse wave Doppler, and which showing the end diastolic velocity. If it's more than 20, is suggestive of, we already discussed, this is the aortic, the suprasternal view, and this is a suprasternal view, and it's showing red arrow. The red actually it's the red jet is suggesting flow towards the probe. Okay, it's the flow is towards the probe, and that is flow reversal. Okay, and this end diastolic velocity is more than 20, suggestive of severe AR. Okay, then pitfalls: depends on the compliance of the aorta, less reliable in older patients. Brief velocity reversal is normal, can be present in AV fistula, arteriovenous fistula in upper extremity, rupture of sinus of Valsalva, left to right shunt across the PDA, reduced compliance of the aorta in the elderly, aortic dissection with the diastolic flow into the false lumen. May not be hollow diastolic in acute AR, acute severe AR or bradycardia. Equilibration of the pressure between the aorta and ventricle before the end of the diastole, leading to flow reversal, that is not hollow diastolic. Then continuous wave Doppler, density of the regurgitant jet. In the apical view, align insonation beam with the flow. Eccentric jets, parasternal window gives a better ultrasound alignment and recording of the jet. Density is proportional to the number of RBC reflecting the signal. Faint or incomplete jet is compatible with the mild or trace AR. This is the AR jet. Okay, this is the AR jet. In the apical long axis, we can 5-chamber view, we can see the AR jet. Okay, the continuous, this one is the continuous wave Doppler. Then pitfalls are qualitative, and central jets appear denser than the eccentric jets of higher severity, overlap between moderate and severe AR. Okay, then coming to the pressure half time, best from the apical view, align insonation beam with the flow. Okay, then the parasternal view in eccentric jets, pressure half time. In if eccentric jets, we can use a parasternal long axis view. A steep slope indicate a more rapid equalization of the pressure between the aorta and the LV during diastole. Mild is greater than 500, moderate is 200 to 500, severe is less than 200. Look, this is the pressure half time. In the apical 5-chamber view, look, do continuous wave Doppler in the AR jet. You can, this is the AR jet, and this is the pressure half time. Okay, which indicates 199, which is severe AR. Okay, then Pressure half time is affected by compliance of the LV. Patients with a severe chronic AR with well compensated ventricular function may have a pressure half time in the moderate range. In patients with a mild AR and severe diastolic dysfunction may have shorter pressure half time. Pitfalls of the pressure half time: its qualitative poor alignment of the Doppler results in lower pressure half time, affected by changes that modify the LV aorta pressure gradient if short implies significant AR or high LV filling pressure. Assessing LV dimensions, ejection fraction, fractional shortening predict outcome in patients with severe AR. Patients with preserved systolic function and increase in the chamber size and systolic dimension of volume is an early manifestation of decompensation and indication for aortic valve replacement. Systolic dysfunction or progressive chamber enlargement together with the symptom status of the patient and his or her exercise capacity needed for management decision in aortic regurgitation. MO, high frequency fluttering of the anterior mitral valve leaflet, the mitral valve chordae or the interventricular septum, the premature valve closure, the premature diastolic opening of the aortic valve. The mode recording of a patient with acute and severe aortic regurgitation demonstrates both fluttering of the anterior mitral leaflet. This is the fluttering of the anterior mitral leaflet and the premature closure of the mitral valve. The premature closure of the mitral valve result of the rapidly increasing diastolic LV pressure. A mode in the acute severe AR. E. Early closure of the mitral valve in acute severe AR. Okay. Note that the mitral valve, the white arrow, okay, closes well before the QRS complex. Okay. Look, this is the mitral valve. The mitral valve is closing well before the QRS complex, indicative pressure equilibration between the LV and LN. Okay. The F is indicating the fine fluttering of the mitral valve at the end diastole in a patient with the aortic regurgitation. Okay, and 2 points: the early closure of the mitral valve and the fluttering of the mitral valve. Then normally the firm opposition of the aortic leaflet causes a single line in diastole. In severe AR, failure of the opposition of the aortic leaflet is double line in diastole. A mode of the bicuspid aortic valve indicates eccentric closure line. Okay. Then grading the severity of the chronic AR with echo: aortic leaflets in mild, normal or abnormal, moderate, normal or abnormal, severe, wide coaptation defect. Okay, in LV size, normal in mild, normal or dilated in moderate, usually dilated in severe. Qualitative Doppler, this is all already we discussed: jet width in LVT color flow convergence, jet density, jet deceleration time in continuous pressure half time, and diastolic flow reversal and descending aorta. Semi-conductive parameters are vena contracta, jet width by LVT width, central jet cross-sectional area by LVT cross-sectional area. Conductive parameters are regurgitant volume, fraction, EROA. Okay, we already discussed this and categorized as mild, moderate and severe. Then role of T is transthoracic echo is an essential first diagnostic test and is frequently sufficient to evaluate the presence and severity of AR. T is usually reserved for more detailed assessment, if needed, of the morphology of the valve and aorta, mechanism of AR, and measurement of the color flow parameters. Infectious or inflammatory endocarditis or isolated aortic root dilatation or acute aortic dissection. Diagnostic value of 2D and 3D TE in defining the mechanism of AR is particularly important for pre-surgical evaluation of the patients undergoing aortic root surgery, valve sparing aortic surgery or valve repair. Okay. Aortic regurgitation, if severe AR, how we determine? By above methods: vena contracta greater than 0.6, hollow diastolic aortic flow reversal, regurgitant volume greater than 60 ml, regurgitant fraction greater than 50%, EROA greater than 0.3 cm square, and if the patient is symptomatic, that belong to the stage D, then the patient has to do aortic valve replacement, is class 1 indication. If asymptomatic, that is stage C, and the LV ejection fraction is less than 55%, that is reduced ejection fraction, is stage C2. So coming to the aortic valve replacement is class 1 indication, and the patient need other cardiac surgery and the patient is asymptomatic and stage C, then it's also a class 1 indication for aortic valve replacement. And the patient has normal ejection fraction and LV and systolic diameter greater than 50 mm and LV and systolic diameter greater than 25 5 mm per meter square. Understood? Who has a is and patient is asymptomatic and have severe AR and the ejection fraction is normal, and LV end systolic diameter is greater than 50 mm and end systolic diameter greater than 25 mm per meter square. Class 2A indication for aortic valve replacement. And the patient is asymptomatic and stage C, but there is progressive decrease in ejection fraction to less than 55 to 60, or increase in LV end diastolic diameter to greater than 65 on at least 3 studies. Low surgical risk, then is a candidate for aortic valve replacement 2B. Coming to the, if the patient is moderate AR, other cardiac surgery, AVR is class 2A indication. Conclusion, here evaluation starts with an assessment of the anatomy of the aortic valve and aortic root to determine the etiology and mechanism of regurgitation, followed by an assessment of the LV size, geometry and function. No single measurement or Doppler parameter is precise enough to quantify AR in individual patients. Integration of the multiple parameters is required. Take home message, specific criteria for severe AR is flail valve. If you see is flail valve, look, that is severe AR. Vena conductor width greater than 0.6 cm, severe AR. Central jet